Welcome, everyone. My name is Tristan North. I'm Senior Vice President of Government Affairs for the American Ambulance Association, and happy that you were able to join us today for a very exciting announcement with the announcement today of the details of the treatment in place waiver by the Centers for Medicare and Medicaid Services. With me today, I have Asbel Montes, who is chair of the AAA Payment Reform Committee, as well as with Acadian Ambulance Service. I also have Brian Werfel of Werfel and Associates, who is the AAA Medicare consultant. And then finally, but last but not least, Kathy Lester of Lester Health Law, who is a consultant to the AAA on legislative and regulatory affairs. So now that we've gone through the introductions, let's get really into the importance and how we got to where we are today with the announcement by CMS with the details of exactly what this waiver will look like for treatment in place. So how did we actually get here? It has been a long and tireless road. The AAA probably started a year ago pushing for the treatment in place waiver, first directly through CMS. We had seen CMS issue a number of waivers early on in the public health emergency. Of particular importance to us is that they did do a waiver on allowing transport to certain alternative destinations. So that was very positive. And we were hoping that CMS could follow suit and additionally issue a waiver for treatment in place for the reimbursement of ambulance services in which a transport of a patient to a medical facility is not provided. This was particularly critical as we saw a number of areas in the US, such as New Rochelle and New York, become epicenters for the US COVID outbreak. And we're seeing firsthand that a number of states, localities, hospitals, other organizations with directive over EMS services were basically directing ambulance service providers and suppliers not to transport lower acuity patients to medical facilities. We also saw a number of patients obviously opting to either not call 911 at all, or if they did and an ambulance responded to a medical emergency, that they were then declining transport because of not wanting to be transported to a hospital and potentially increase their exposure to COVID-19. So the AAA had pressed the envelope as far as it could with CMS, only to learn that they thought they did not have the authority in which to issue the waiver. Our attention had already been on Capitol Hill and seeing what we could do there, but it became more acutely aware that we were going to need legislation to get this done. And working with the International Association of Fire Chiefs, International Association of Firefighters, National Association of EMTs, as well as champions on Capitol Hill, in particular, Senators Cortez Masto, Democrat of Nevada, as well as Asbel's home senator, Senator Casey, Republican of Louisiana, and then also, in particular, Democratic Senate leadership with Senator Wyden, who at the time was ranking member of the Senate Finance Committee, now chairman of the Senate Finance Committee, and now Senate Majority Leader Chuck Schumer, in really getting this done, as well as we had assistance from a number of folks on the House side, including Congresswoman Axney and Representatives Westerman and Westerman, as well as Larson. So really, this was kind of a team effort. We had been looking for different legislative vehicles in which to get this done. And finally, with the American Rescue Plan rolling around, folks will recall that's the $1.9 trillion package that the Biden administration had put forward on COVID relief, was really the vehicle. While there wasn't a lot in there as far as assistance for Medicare providers and suppliers, this issue was so critical and vital to get done that we saw really on the Senate side a really strong push by the champions that I just mentioned in getting it included, and then the support from the House side. And finally, on I believe it was March 11th, we saw President Biden sign into law the American Rescue Plan, and importantly for us, finally the direction to CMS giving them the authority to issue a treatment in place waiver. So with that, I think I'm going to then turn it over to, Asbel, who's going to go into a little bit more detail on what treatment in place means, or are we going to be, is Brian going to take care of that?
Well, I think I'm going to start, and then we're certainly going to turn it over to Asbel. So I'm going to give the sort of classic definition of treatment in place, and then I'll walk everyone through how that's evolved into the ET3 program, and then Asbel's going to sort of jump off from that definition into what we're talking about here. So treatment in place is exactly that. It is the treatment you render to a patient at the scene that doesn't result in them being loaded into the vehicle and transported. And I think one of the key things here is, and while it's not necessarily mentioned in the definition, I think it is important to distinguish between that situation where it would be the ambulance company's preference or opinion that transportation was warranted, in order to get the patient to the hospital for further care, but where the patient is simply refusing to be transported, or what we would call an RMA, or an against medical advice, right? What I think is generally understood to be treatment in place is where the ambulance crew is able to successfully resolve that patient's emergency or acute condition at the scene, and therefore there is no need for further care at the hospital. So, in an extreme example, this would be a minor laceration where they bandage it, a minor sprain where they provide an ice pack, right? But it can also include some more, intensive interventions, placing the patient on a cardiac monitor, determining that they are not in cardiac distress, and then determining that it would be reasonable to leave them at the scene. All of that would be treatment in place, because when the ambulance crew departs, it's not with the patient, and it's not because the patient is elected not to receive further care. It's because it's not reasonable to believe there is a need for further care, right? ET3 sort of piggybacks on top of that definition, that we've successfully resolved that patient's emergency condition without the need for the transport. It just adds in the component under certain circumstances where that would include a telehealth encounter with a appropriate qualified healthcare practitioner. So they may do their own assessment of that patient through that telehealth encounter, walk the patient through what the potential risks are, then allow the ambulance company to treat them, and then we've resolved the condition and off we go, right? Now, Asbel, are you ready?
Hey, I'm ready, and it is Cinco de Mayo. That's all I have to say.
All right, so what we can't see is his margarita below the screen, but Asbel, you want to walk through where treatment in place sort of differs from what we're talking about with this waiver?
Yes. So as Brian was just saying too, practically, and then they'll get into the technical side of this, guys. Now we get into a very limited scope of what this treatment in place waiver is doing. And you need to think about it in the context of, if I have a community-wide protocol, and there was a lot of debate around that community-wide protocol when the waiver actually came out, or the waiver was actually implemented, or they were given waiver authority under ARPA, that there was that community-wide protocol piece of it. But that community-wide protocol was to manage the arguments that we were making, saying in some of these areas where there was an epicenter of the pandemic, of the COVID outbreak, that it relied on patients not being able to go, or for low acuity patients that normally would have called 911 and you would have transported them to the ED, but they wanted you to kind of treat them in place, maybe refer them to a doctor or something like that. Do not transport them. There were some areas where they said, do not transport patients unless they are priority 1 type patients, unless they're having a heart attack, a stroke, then you take them to the nearest appropriate facility. You had some that were on diversion. That is debatable as we walk through this process when you look at the webinar. But there are requirements in there when you're practically saying it, when people are looking at it, that it is not the AMA. as Brian was just talking through, and there's specific direction given through this. So the treatment in place as it's looking here, guys, it's going to be under that scope where you were told by either verbal orders, written orders, by a hospital, by your medical director to treat these patients in place that otherwise normally would have gone to the hospital, and do not transport them because of the pandemic and because of the surge capacity or whatever your community was dealing with at that time. And I know we're going to go into more of the technical application of it, but a lot of people are having questions around, well, how do you bill for that? What if we're not billing appropriately? Remember, this is a waiver, just like all of the other waivers that have been initiated that give you lenience to do certain things based upon the qualifications and what's in that technical component of the waiver, which Brian and Kathy are going to go over now. But that's just kind of the practical application to treatment in place. It is very narrow in scope, and that is what we need to stress here. It's not ET3. It's not treatment in place, as Brian Werfel just indicated as well. So I'll turn that back over to you, Brian.
And actually, Brian, if I can just jump in a moment, this is Kathy. I think one of the things that it's really important to remember is why the Congress gave this authority to CMS and why CMS implemented it. There's a real understanding that being on the front lines, and particularly in areas that experienced a high number of COVID cases, there were solid public health reasons not to transport certain patients that would have otherwise been transported, but for these community-wide EMS protocols. And so I think as you think about what will qualify, and as we talk about the parameters, it's really important to keep that in mind. This is about responding to the public health emergency, not necessarily looking at broader policy at the moment. And that's why you see it tailored. So it's hopefully easier to document, to bill, and to have you all made whole as much as you can at the end of the day for the services that you provided for which there was not transport, but being consistent with the rules and the needs of the community you were serving.
Yeah, I mean, as someone that lives in New York, I can tell you that, each day in the local papers, you were reading talks about how many ICU beds were left, how many ventilators were left. That's, if many of you recall, President Trump did dispatch one of the hospital emergency ships to the harbor. We did open up a famous hospital here in Central Park on a temporary basis. So there was a genuine concern here in New York about hospital capacity. But Asbel or Kathy, I do want to throw a question to you guys. And that is, we seem to be stressing this notion that this is or intended to be fairly limited. We're not getting this out of left field, right? My understanding is that there was a very limited GAO score on this.
Right, but also the parameters that are in the statute really focus CMS in, right? So in order for this waiver to apply, first, it has to be in response to a 911 or the equivalent in your community call. Second, then when you got to the scene, the patient would have been transported, so would have met medical necessity requirements, but because there was either a written or a verbal community-wide EMS protocol in place that said, we're not going to transport these types of patients, stabilize them at home, maybe even monitor them or connect them with another service, then that patient was not transported, who would have already been, right, but for the public health emergency. And so that's the limited scope that you see around it. It's really meant, and Brian mentions the CBO score, because it's really meant for patients who you would have transported and would have been reimbursed for legitimately under the Medicare program, but could not be. So the idea was not to expand any new benefit here, but to really compensate you for the care that was provided that you should have been compensated for and would have been, but for this emergency.
I think we've received a question from our audience here. Isaac would like to know, how do you know that a patient would have been transported in the absence of a transport?
So you should be making that assessment at the scene, right? Anytime that you are with a patient and they're they need to meet the medical necessity requirements. So if you are following one of these protocols, and some of you may have these, you knew they were in place, some were from the hospital system, some were from the public health authorities, and they could be very, very clear. And this is a plug for our webinar next week, where we'll go through some examples of those. But you would see that, for example, if this is a patient that was maybe bedridden, or you would have taken to a hospital for further observation, would meet those medical necessity requirements for medical transport, and Brian can go through some more examples of those, then you would have transported them. But in this case, the public health emergency would have said, perhaps a low acuity patients who would be normally transported would not be transported in this case. Keep them in their home at the scene, or in their location. So the whole point is that it is being governed by those protocols. And so between your existing understanding of how you comply with the medical necessity requirements, plus those protocols, you should have documentations in the record that would demonstrate whether the patient would have been transported or not.
Right. So we do have one other question. It's in the chat, and I think that this will actually be a little helpful to us in sort of illustrating where this is. So the question is, how do unsuccessful cardiac arrests fit in? And I'll assume that what we mean is unsuccessful in the sense that we were not able to resuscitate the patient, or at least get some sort of cardiac function back, right? So really, I think what we're saying is these are patients that under normal circumstances might have been transported to the hospital in the hope, faint as it was, that they might be able to restore these patients back to a normal heart rhythm. But that given the limited resources, they're making a conscious decision to sort of let them go at the scene. I assume Tony is asking the question from California, because I do know that Los Angeles did implement a similar protocol. I imagine that there were other ones in other areas of the country. So the question here is what lawyers would tend to call a but-for analysis. So the really is, under normal circumstances, before the pandemic, is this the sort of patient that you would have loaded into your vehicle and driven to the hospital? Well, in a cardiac arrest situation, there are usually fairly strict or well-defined protocols for when it is appropriate to transport them or when it is appropriate to not transport them. Many of them are written in the negative, right? Do not discontinue efforts unless you go without, a valid pulse for at least 5 minutes, right? Or multiple injections of epi, et cetera, right? So that would be your existing standing treatment protocol. What we're looking for is whether or not that protocol was revised in response to the pandemic, right? So if the protocol was, to use an easy example, you are not allowed to pronounce them dead in the field. You are not allowed to call into medical control and have them pronounce this patient dead in the field. All of these patients must be loaded and taken to the hospital, where they will not be declared dead until a physician provides at least an initial assessment. And that protocol was revised after March 1st of last year to say that, notwithstanding our previous protocols, these patients should not be transported. Then that would be the delta, right? Those patients that would have been transported under the previous protocol that are now not transported are the ones that this would apply to. Anyone else, it would not apply to, right? So if the previous protocol allowed you or required you to leave them at the scene, right? Nothing has changed as a result of COVID. Kathy or Asbel, correct me if I'm not saying this correctly, but those would not be eligible for this TIP because nothing's changed as a result of COVID.
And that would be correct, Brian. And especially when it deals with the ones that are in cardiac arrest, or you were dispatched and then announced, maybe that you changed the protocol. Now they're being, you're calling into either the coroner or you're calling into someone to pronounce them dead. Remember, there's another, you would apply the QL modifier, and that we'll go into some details on that as well. Now, CMS in their FAQs actually opines specifically on those examples as well. So we'll go over some of that stuff in detail as well, because that cardiac arrest is kind of nuanced, and that is some of you guys is going through that process too. Brian, but that we probably need to give some clarity around that, because I know there's some questions, and because in different parts of the country as well, where people are billing based upon, because that QL has been around forever and a day. And it is a little bit more nuanced than this is. So you'll need to understand what Brian just said. And that's where the detail is going to come in. And I think it's another important point to note, and I'll let Kathy opine on this as well, that CMS has given the guidance. The guidance is out, it's under waiver. It's not like they're gonna do an MLN on this, or say, hey, we're gonna have we're gonna give you guidelines on how to do billing on this. This is a waiver very similar to all of the other waivers as well. And so I think we need to understand that. And that's kind of why we're going to give a practical application on a webinar and kind of walk you guys through some different scenarios on how the billing should be conducted on this.
Thank you so much for that, Asbel. We actually have a question from Deb Galt, who has raised her hand, and we're going to let her talk out loud. So Deb, I've asked you to unmute if you'd like to go ahead.
I actually didn't know that my hand was raised, Amanda. I tried to unraise it. I apologize.
Well, that's just Facebook Live for you. So it's nice to hear your voice, and I'm sure you'll have a question in the future.
Thank you. I'm sorry.
Perfect. We've gotten some other questions in the chat as well. Someone would like to know, what if the patient refused transport because they were scared to go to the hospital?
So it's you know, and it's most likely not going to apply under this waiver. So if you had a protocol, right, that was specific to a disease or a condition, you know, and that patient didn't fall within that scope of the COVID related waiver, and just refused because maybe they were in a car accident and they were worried and just, you know, didn't want to go. That's not included, because you can imagine how difficult that would be to document for CMS and the audit process. And that would really be sort of expanding the definition and scope of the benefit. But if the protocol said, if you had someone in respiratory distress or in maybe diabetic shock and you were able to stabilize them at the scene, and I'm just using this as an example, but the patient then, you know, does not want to go to the hospital, and they're not suggesting that they're not going to do that over your objections, then that very well may fall within the protocol. So what you really need to do is look at the protocols and how they were written. CMS did use this as an example on a call that they had today with industry leaders of trying to distinguish between people who were maybe more like me and just didn't want to be at a hospital during the middle of a pandemic surge, as opposed to people who were being identified by public health authorities, hospitals, you know, others in the community as not being appropriate to move forward. And in some cases, the patient may agree with you, and that's fine. That would still fit that protocol, but a simple refusal because I'm scared would not. And can I add in here too, Amanda, one of the things that I think is also very important about this waiver, and I believe Asbel and Brian have already touched on it, is the waiver is retroactive. So it actually, for any transport, March 1st, 2020, so last year, all the way up until the end of this public health emergency, which we don't know when it will end, is under this waiver. So you can evaluate claims that you may not have billed for, or that have occurred prior to today. But there is an important component to this waiver that we want everyone to really pay particular attention to. And that is that the Office of Inspector General has waived the prohibition on waiving patient coinsurance, which means you could bill a claim for, say, last April under the treatment in place waiver and not have to seek the 20% copay from the patient, which you normally are required to do under the Medicare program. I think it's really important that they put this waiver in place and that everyone really sort of thinks about how to apply that, because there is a lot of concern that this is providing a service that the beneficiary didn't anticipate. And, while Medicare is going to give you the 80% of either the BLS or the ALS amount, whichever was the appropriate way you were dispatched, you also want to think about the impact on the patient. And so, there is a hope that the industry will recognize that that could be a very big hardship on the patient and not seek the co-insurance that was rightfully due, in retroactively applying the waiver. Maybe a slightly different story going forward, but certainly trying to collect a copayment that's 13 months old could be incredibly difficult. The other thing is, if you did actually already bill the patient and the patient paid some or all of that bill, you need to refund the patient the amount that they paid you minus whatever that copayment was. Now, you can waive the copayment and refund the entire amount, but you could also legitimately hold on to the copayment amount, and then Medicare will bill you the 80%. So as you can see, there is a consumer protection here. And as you know, surprise billing is a big topic here in Washington and within states across the country. And so it is important, and I think useful, to think about the OIG waiver to try to make sure you don't find yourself in, sort of a difficult position with patients because you are retroactively applying this waiver, or because they are surprised that they are getting a bill when they are not being transported.
Kathy, can you, I know we talked about the retroactivity piece, but can you also just talk about how protocols fall into that retroactivity piece? So one of the questions that's come up is this only applicable to a situation where the protocol was in effect in the past, but just I couldn't take advantage of it due to the lack of this waiver? Or can I go back now and retroactively impose a protocol?
Yeah. So the protocol would have had to have been in place at the time the services were provided. So you can't retroactively create a protocol. That is something that is prospective in nature only. So for example, we know there were protocols in New York asking for low acuity patients to remain at their home or their location and not be transported to the hospitals. Those that may have been dated in January, they may have been dated in March 2020, they can be used, but only on a prospective basis. So you need to look at the date at which that protocol was in place. This is not a way to sort of go back and rethink how your community responded to the pandemic, but a proactive way to try to address those of you who were following the requirements of your communities, or the working together to make the best outcome possible for hospitals, emergency care patients, and the community at large.
You can certainly implement a protocol today to deal with future trips.
Correct.
Right. But again, and this is, and we want to stress this point over and over and over again, this is why the CBO gave this a very small score, right? This is not a backdoor into all treatment in place. This is a very narrow exception, and it may not apply to many, if not most of you on this call, right? So look at your protocols as they existed on March 1st of last year. Look at the protocols to see how they may have changed within the last 13, 15 months or so, right? What you are looking to identify are those trips, or those responses, where you responded, treated, and did not transport because of something that changed in those protocols between as they stood on last March and as they look today, right? That is a very narrow window we're trying to squeeze these claims through, right? So just be mindful of that.
And the other thing I would add is, just if you had a treatment in place waiver because or protocol in place because you were providing treatment in place services to a commercial plan or a Medicaid plan, and that was a waiver that existed previous to the pandemic and outside the scope of the pandemic, that does not qualify. The protocol has to have been created in response to the COVID-19 pandemic. So again, we're still in the PHE. There are still hot spots, and we all hope those go away and we don't see other ones come up. But you can do that prospectively as a community to respond to the issues that you're seeing. But again, the waivers need to be tied to the pandemic specifically.
Thank you so much for that, Kathy and Brian. We can tell by the fact that everyone's hanging on here at well after 5 o'clock on the East Coast that there's a ton of questions and interest in this topic. Is there by chance a different opportunity for folks to hear more about treatment in place and this waiver?
And yes, actually, Amanda, there's another opportunity coming up next week, May 12th at 3 p.m. where we'll have, I believe, Brian, Kathy, Asbel, and I think Scott Moore that will be giving much more in-depth information for folks and an opportunity for additional questions once people have had time to digest the fact sheet on the waiver. And also, while the AAA had a great victory with this treatment in place waiver, we want to keep this going and making sure that ground ambulance service providers are helped during the COVID public health emergency. The American Ambulance Association actually is sending a letter today to the Department of Health and Human Services asking them to release money to ground ambulance services from the Provider Relief Fund. We believe they have about $20 billion, $22 billion left, in addition to $8.5 billion specifically in funding for rural healthcare providers. So this is another area where the AAA is trying to get ground ambulance service providers and suppliers more money to offset the increased cost and reduced revenue as a result of public health emergency. And then setting the public health emergency aside, although obviously it directly impacts our Medicare ambulance relief because we've seen CMS do a 2-year delay on ambulance data collection, that we need to make sure that we don't let the Medicare ambulance add-ons expire, the 2% urban, 3% rural, super rural bonus payment at the end of next year. So we are asking AAA members, everyone on this call, feel free to send to your state ambulance associations to reach out to your members of Congress and ask them to co-sponsor the Protecting Access to Ground Ambulance Medical Services Act of 2021, HR 2454. And Amanda has put up a screenshot of our call to action. And this legislation by Congresswoman Terry Sewell, as well as Congressman Nunes, Welch, and Mullen, will increase or actually extend those increases for another 5 years to give us time to deal with data collection, the MedPAC report, and then giving Congress a little time to act on the data, as well as addressing the zip codes and change in geographical definitions that we could see following the 2020 census to hopefully preserve more of those rural zip codes that we all would agree are rural to being rural after the 2020 census. So if you haven't already, please log on to the AAA website, go to the advocacy section where you'll see this call to action center and write your members of Congress today in asking them to co-sponsor the bill. We hope that Senator Cortez Masto and others will be introducing a Senate companion bill in the next couple of weeks, and we'll be doing a follow-up call to action. So, even though we've seen a great victory here on treatment in place, we got to keep this going, and we got to make sure that we don't lose those Medicare ambulance add-ons, and we can't do it without your help. Kathy, Brian, anything else that we may have missed? Amanda, Stars of Life?
No, I think we got it. Hope we got it.
Since each of our presenters today are AAA and EMS celebrities, if seeing them on your computer screen isn't enough, we really encourage you to visit annual.ambulance.org to register for our annual conference, which will take place in Grapevine, Texas, November 1st through 3rd. Additionally, this year, we're really excited that our Stars of Life EMS recognition event will be co-located with Annual and will take place November 2nd and 3rd in the same place. So come see Brian, Kathy, Tristan, and Asbel in real life, face-to-face in Texas this November, after you watch them next Wednesday on the longer format Treatment in Place webinar. So thank you everyone for joining us. This recording will be emailed to all members in the Daily Digest tomorrow, or should be accessible momentarily on the AAA's Facebook page. Anything else, Tristan?
No, I think that covers it. Brian, Kathy?
No, just thank you all for joining. It's a
Yep.
very exciting time and glad we were able to get this in place to provide folks with some relief during the pandemic.
Thank you, everyone. And this concludes today's broadcast. We will see you on the 12th.
Bye, thank you.